Hi, everyone. Today's conversation is on clinical trials, immunotherapy, and gynecologic cancer with Dr. Thomas Marron, who's MD, PhD. The description of today's talk is join us for an informative session focused on the latest advances in clinical trials and immunotherapy for gynecologic cancers. This presentation will cover current research, the role of immunotherapy in treatment, and how patients can access and participate in clinical trials. Designed for patients, caregivers, and healthcare providers, this session aims to empower participants in knowledge and support informed decision making. About Dr. Marron. Dr. Marron is the director of the Early Phase Trials Unit at the Tisch Cancer Institute, professor of medicine, hematology, and medical oncology, and professor of immunology and immunotherapy at the Icahn School of Medicine at Mount Sinai. He is a medical oncologist and holds a PhD in immunology. His research focuses on development of cancer immunotherapies. So, Dr. Marron, we are so thrilled to have you. Thank you for joining us today. And you're muted.
Sorry, I should have corrected the title. So I'm not specifically going to talk about gynecologic malignancies. I'm technically, my side gig is that I'm actually a lung cancer doctor, but I spend most of my time treating patients in the phase 1 unit at Mount Sinai. And these are new drugs. Primarily, my interest is on new immune therapies. And there I do treat lots of patients with gynecologic malignancies and gastrointestinal malignancies. But I think you guys had Dr. Zamaran speak to you as well, and he's really one of the world's experts in immunotherapy specifically for gyn malignancies. But a lot of what we're going to talk about, I just sort of wanted to basically hit on two things. One is I wanted to give you a little bit of an overview of what immunotherapy is. And I'm going to give you one example of some of the research we do. There's a little bit of science in there, but well, bear with me. I just want to give you an example of one of the ways in which we are sort of furthering our understanding of the immune system and how we can improve on the therapies, because most immunotherapies are not super effective right now in gynecologic malignancies outside of maybe endometrial cancer. And then I'll talk to you a little bit about how clinical trials work. I think that everyone got sort of a crash test or a crash education in phase 1, 2, and 3 when we were hearing about all the COVID vaccines back in the day. So I just wanted to give you a general idea of what that means, because I know a lot of people will end up seeing, a doctor, whether it be their gynecologic oncologist or a phase 1 doctor like me, and they'll ask about what, if a trial is phase 1 or 2, and I just wanted to give you an idea of what all those numbers mean and the different steps of developing a drug and going from, developing a medicine in mice and actually putting it into humans. So first, what is immunotherapy? So your immune system is in your body to tell the difference between foreign things and normal things. And you have all of these signals that activate your immune system. So if you have, let's say, viral particles or bacterial, things in your blood that activates the immune system. These are foreign things that shouldn't be in your body. On the other side, you don't want your immune system attacking most of what's in your body, whether it be even the bacteria in your gut, or your skin or your lungs, because if your immune system starts attacking normal things, that causes disease also. And it's this delicate balance between activation signals and sort of tolerogenic or inhibition signals that is disrupted.
Struck by a train as she tried to get back up on the
And what happens is this process of carcinogenesis, which is the development of cancer, and that might be due to just a normal living in New York because you have lots of pollution, or smoking cigarettes or laying out at the beach and getting all the sun exposure. As you get more and more mutations in your DNA of all your cells, eventually your cells become more and more foreign looking, more and more amenable to recognition by the immune system. But also, as they become foreign, they might start growing in a haphazard way, and that's what cancer is. Cancer is always related to mutations or changes in the DNA, because your DNA is basically your instruction booklet on how every cell in your body should grow. And sometimes if you have a specific change in that instruction booklet, all of a sudden the cell is growing too much, and that's what a tumor is. And you should say, your immune system's there to tell the difference between foreign things and normal things, and nobody is born with cancer. So it is by definition foreign. It's not as foreign looking as COVID, but it is foreign. And so your immune system should recognize and attack it. But what happens is cancer basically puts up all these stop signs. It has dozens of different ways in which it hijacks the immune system and turns the immune system off. So I always sort of use this description with my patients and say, tumor cells are putting up stop signs. One of the stop signs that we have a lot of drugs to target is something called PDL1 or programmed death ligand 1. And basically, even if you have a T cell, which is one of the most important immune cells in your body to recognize and kill cancer. Everyone's heard of T cells because of HIV. And AIDS patients who don't have T cells, along with getting infections, oftentimes will develop cancers because your T cells are so important to preventing cancers and sort of surveilling your body for cancers. So your T cell should recognize any tumor cell, but if a tumor cell puts up these stop signs, the T cell basically turns off. It goes to sleep. And so what we have done with lots of drugs is we have developed these checkpoint blocking antibodies, which are basically proteins that bind to that stop sign and basically masks the stop sign. So it's sort of like throwing a sheet over the stop sign so the T cell doesn't see it. So the T cell says, hey, that's cancer, and it goes ahead and kills the cancer. So these checkpoint blocking antibodies, many of you have heard about these because they were helpful at curing Jimmy Carter of cancer. He lived for another 15 years after developing metastatic melanoma that went to his brain. Many people have heard about them also because they advertise them on Monday Night Football and all over television. They're some of the most advertised drugs out there. And they have all these kind of ridiculous names that they come up with and lots of basically copycat drugs amongst them. And cancer immunotherapy, and specifically these checkpoint blocking antibodies, is really exciting because it really has transformed the way in which we treat many solid cancers. So skin cancer is a perfect example, and this is one of the first phase 3 trials that was run in melanoma. So this was a trial that led to the approval of immunotherapy as the first line treatment for melanoma. So before, back in 2015, if you got melanoma, the average patient with melanoma only lived about 9 months. And everyone with metastatic melanoma, meaning melanoma that spread to their brain or elsewhere in their body, would eventually die from the cancer. So in this study, they took patients and they gave half of them dacarbazine, which is an old-fashioned chemotherapy. The other half got nivolumab, which is an antibody against PD-1. So it's one of those things that, turns the stop sign off. And this is what we call a Kaplan-Meier curve. So on the y-axis, this up and down axis, you see the percent of patients that are surviving. So 100% are surviving on day one. On the x-axis or the horizontal axis, it's time. And you can see as time progresses, the dacarbazine, the patients in the chemotherapy arm, the number of them that are surviving goes down and eventually gets to 0 at around 2 years. But you can see here the patients being treated with nivolumab are doing much better. And this is a subsequent study looking at a combination of nivolumab and even another medicine called ipilimumab or Yervoy. And this similarly showed really nice responses here on the x-axis, or on the y, or the x-axis is months. And so this is, going out 3 years. You can see 39% of these patients are living without any cancer. So this isn't just survival, this is survival without cancer. And so what we see are plateaus forming here. So the curves aren't just going down. We're used to dacarbazine sort of curves where unfortunately chemo doesn't cure most patients. And so the curve always goes to 0. Here we're seeing these plateaus form. And when we see plateaus form, we start breaking out the champagne because this really means that we are curing patients of cancer. And this, the word cure was a word that we didn't feel comfortable using in the setting of metastatic cancer in general because we knew it, was unfortunately deadly for just about everyone. But all of a sudden here in melanoma, we're probably curing somewhere between 40 to 50% of metastatic melanoma at this point. And so immunotherapy has revolutionized the care of many patients. As I said, the only patients I see outside of a clinical trial are lung cancer patients. And lung cancer was similarly, universally fatal. The average life expectancy for chemo, if you had metastatic lung cancer, was only around 10 months back before immunotherapy. But immunotherapy more than doubled that. And this is a curve showing the recurrence risk. So the patients without cancer coming back if they undergo surgery. And if we give immune therapy before and after surgery, you see here that patients do much better. So many more of these patients, probably around 50% of them, are cured with a combination of surgery and then immunotherapy. But when I see curves like this, obviously as an oncologist, I'm very excited. My clinic is much busier than it ever was in the past. I think the elephant in the room always is that obviously many of these patients are still having their cancer come back and are still unfortunately dying from their cancer. So we still have a lot of work to do. So I'll tell you a little bit of the one of the scientific stories of what we do in the lab. So at the Tisch Cancer Institute, up on 102nd and Madison Avenue, we see patients on the third and fourth floor of the building. But on the fifth and the sixth floor, we have a slew of labs that are doing research not only on, biopsies and tissue that are donated from patients on the third and fourth floor, and we run them upstairs, but also we do a lot of studies on mice to try to understand how cancer is progressing, what the immune system is doing to that cancer, and how we can better harness the immune system to recognize and attack cancer. So how do we improve outcomes? So one of the things that we've been doing for 15 years at this point is we've really just been studying what the immune system looks like in humans. So, a lot of the times people will do studies in mice or monkeys, but we're not inbred rodents. We don't give cancer to monkeys, and so we don't even know what cancer looks like in monkeys, but mice and us have very little in common. So we really have focused most of our efforts to understand the immune system in tumors, and the place that we started was we basically just took patient tumors that were being cut out. We always ask permission from patients when we say after we bring it to the pathologist and they look at it under the microscope, can we have what otherwise would basically just be thrown away? And can we bring it back to the lab and can we study it and understand what's going on? And by studying these untreated tumors that are removed, we can hopefully learn about the normal immune response to cancer. So what is going on in the tumor, what those immune cells are doing. We can learn all the different ways in which immune system is hijacked. And there's numerous ways, and everybody's tumor is a little bit different, and everybody's immune system is a little bit different. So that heterogeneity, that sort of mishmash of different approaches is important to know so that we can know the best therapy to give to each individual person. And the goal of all this science, even though we're not necessarily studying therapy here, is really to understand the baseline, how things look today, so that we can develop new therapies and improve how patients respond tomorrow. And we use a variety of very high resolution, sort of fancy technologies, many of which have actually been developed at Mount Sinai, to understand, look at the tissue and look at each individual immune cell of the millions of immune cells in the tumor and really understand, what's happening. So I always think this is a nice picture to really explain that. By the way, if anybody has questions, feel free to stop me at any point. I don't need to just sort of didactically lecture you, and we're going to get to the trials in a second. I just want to give you one example of one of the things that we're doing that I think is very applicable, particularly to certain gynecologic malignancies like ovarian cancer. So if you take a tumor out and you look at it under the microscope, this really emphasizes that cancer is a disease of the immune system. So you can see here, this whole thing theoretically would be a tumor, but the only part that's actually cancer cells are these red cells right here in the middle. The rest of these cells are immune cells and connective tissue cells that are actually surrounding the tumor. And they're not, unfortunately, killing the tumor. They're actually kind of protecting the tumor and allowing the tumor to grow and also eventually spread. And the immune therapies that we have, the checkpoint blocking therapies, they act on your T cells, which are your CD8 T cells in particular. So that's these light blue ones here. And in lung cancer, stomach cancer, bowel, breast, bladder, every cancer you look at, they're actually a very small percent, maybe 10 to 20% of the cells at most are these cancer fighting T cells. The most common cells in the tumor are these macrophages. So macrophages are an immune cell, super important in your body. They basically are the janitor cell of the immune system. They clean up dead stuff, but they also are very important teachers of the immune system. So they're able to teach your T cells what to kill and what not to kill. So I told you about that balance at the beginning. Your immune system you want it to kill foreign things and not kill normal things. Your macrophages are kind of the professor cell that says, hey, kill this, but don't kill this. So we were interested, we have all these therapies being developed that target this tiny little 5 to 10 to maybe 15% of cells in the body or in the tumor. Why don't we, think about developing drugs that target macrophages because they make up, 40 to 60% of the immune cells in the tumor. So we've been studying these using all those technologies that I talked about earlier. And in lung cancer, and we also see this in ovarian cancer and colon cancer and liver cancer. We've done it in all the tumor types at this point. When we look at those macrophages and we say, what is it that's funny about them? How can we basically repolarize them, re-educate them. So instead of allowing the tumor to grow, they actually control the tumor growth. And when we look at them, we see this thing that we call an IL-4 signature. So basically, the reason this is important is interleukin-4 is a part of your immune system that's very important for allergy and atopic diseases. So like asthma, eczema, a variety of different sort of inflammatory conditions in your skin and your intestines. And as everybody here who has any exposure to young kids knows, food allergy is skyrocketing. And so food allergy is the ultimate, Th2 type 2 immune response that for some reason now is much more common than it was when I was a kid, where we could have normal bake sales. Now you can't have a bake sale because kids have such scary allergies to, eggs and peanuts and everything else under the sun. So when we think about the immune system, I always sort of think of it in this way that I learned back in medical school, where there's really a dichotomy in your immune system. And one part of your immune system, we call it the type 1 immune system, is very important for antiviral responses like anti-COVID or anti-tumor responses. And then on the other side of the sort of seesaw here is type 2 immunity. And type 2 immunity back in the day when we, lived in the jungle, it was very important to protect us from things like helminths or worms or parasites. But because we use lots of Purell and bleach, we don't get exposed to that anymore. And so now the theory, the hypothesis that we call the hygiene hypothesis, is because we use so much bleach and everything else, now that part of your immune system is sort of sitting there not doing anything. And all of a sudden it is promoting things like atopy, so asthma, allergies, food allergies, things like that. And it also, we know, is very pro-tumor, because we know that patients that have a very strong allergic fingerprint actually do much worse than those that don't. Mary Benjamin, you have your hand raised.
Yes, hi, good afternoon. So, I was thinking like Rich. Okay, I'm an ex breast cancer triple negative patient. And we know with the adjuvant way of treatment, we have the surgery first. Okay, so I imagine that rich people are able to afford the following: having the tumor removed naturally in the first step of the surgery, and then taking that tumor and having it tested on in kind of like petri dishes or something to see what drug would work best, because as you know, it could be 1,000 women with the same diagnosis. However, we're different inside the immune system and what response. So this is my imagination, like that would be a targeted therapy that we know that woman what would respond and work best with her type of tumor markers and so on. So I don't know if what I'm saying makes sense. I don't know if rich people are already doing stuff like that in targeted clinics. And I always say that cancer is not for middle class or poor people, it's for rich people because yeah.
Yeah,
Okay.
there are some labs that will do that. A rich person, you have to have a lot of money to do that. You can test it. You can basically try to find ways to test it in vitro. It actually doesn't work. There's really we've done clinical trials at Sinai that are all of our trials are for everyone, not just rich people, where we actually took people's tumors and we took their mutations and we put it into fruit flies and we tested all sorts of drugs on the fruit flies and then we brought it back to the patients. Unfortunately, it only worked maybe 1 out of 20 times. And so we're not yet, in an ideal world, we can be in this personalized space where we can take someone's tumor, to your point, and we can study it in the lab and tell you exactly what the best medicine is for you. But we're not there yet because we can't recapitulate your immune system, your body, all the different components of the whole body is basically allowing the tumor to grow, and we can't recapitulate your whole body in the lab. So I think that, ideally we'll be there in 10 to 20 years, but unfortunately it's not, on the precipice of being accessible. So even if you're rich, it ain't gonna help, unfortunately.
Thank you for your response.
Sure. So basically, I'm just going to summarize. What we figured in the end was that the tumor secretes lots of stuff that hijacks your body, and it basically turns your body into this very allergic sort of signature. So when we realized that when we were looking at tumors, it looked very similar to our colleagues in dermatology that were studying kids with really bad eczema. They had very similar sort of immune perturbations, immune dysregulation. And so we said, well, that's funny. Well, why don't we block that immune response? And in mice, we actually did that, and we were able to keep the cancer from growing. We were able to cure the cancer using an allergy medicine that blocks IL-4, that blocks that whole allergic side of things. So we saw that in the lab. We basically made an observation in human tissue, which is why it's so important that patients are donating this tissue to us. We bring it back, we study it in mice, but again, mice are not perfect. And so then we bring it from mice back into humans and we say, all right, what does it do in humans? And we knew that there's a drug called dupilumab or Dupixent that's actually probably the only drug that's advertised even more than cancer immunotherapies on television because it's now FDA approved to treat all sorts of different things, including atopic dermatitis, which is eczema, asthma. It's also approved for COPD now in smokers. So we knew it was very safe. It's even given to kids as young as 1 who have this rare condition called eosinophilic esophagitis. So we know it's safe if you're giving it to a 1-year-old. So we basically said, well, let's try this in humans. And so we took that human data, we brought it back to the lab, studied it in mice, and then we brought it straight into humans. And we did this clinical trial. And so this is a trial where we included 21 of our patients. These are my patients with lung cancer that have received immunotherapy already, the checkpoint blockade, like pembrolizumab or nivolumab. So they received it, and then usually it works for a while, but unfortunately for most patients, it eventually stops working. And all we did was continue that medicine that had stopped working, and we added on 3 injections of allergy medicine. So this is the dupilumab, the medicine that's FDA approved for all those other things. And our goal here was to see if this could kind of basically hit the restart button on your immune system, get your immune system back to working and attacking the cancer. And we have just finished this study. We actually opened version 2.0 of this study. But even in the first 6 patients, one of the patients actually went into remission. So this is this first image here on the left. This was a patient. He was a smoker. He had had chemotherapy and radiation. And after that, we typically give immunotherapy for a year because we know it increases the likelihood that you're cured. But unfortunately, you can see here all this yellow stuff. We thought maybe it was just inflammation. But then in the second image here, you see that it's much larger 3 months later. So this told us, oh, their cancer was growing. This is in their back. This one on the bottom is in their lungs. They had cancer growing many different places. We gave them basically just continued what they were getting, the immunotherapy, and we added 3 injections of the allergy medicine. And then this image here, you can see everything looks better in this post-treatment 1 image and post-treatment 2 image, the patient had gone into remission. Basically, I don't know if some of you have looked at PET scans before, I'm sure, but the bright stuff is what we worry about. The bright stuff is cancer, and you can see all the bright stuff is basically going away. So that's very promising. Now we have because we see this works in patients who have, metastatic disease that has spread and they don't have very good options anymore. Now we're bringing it to patients who are having surgery to see if we can increase the likelihood the surgery cures it. So we have this trial where we're giving a single dose of the immunotherapy and a single dose of the allergy medicine. And then about 2 weeks later, we cut their tumor out. And this is being run by one of our surgeons. And also we have a collaborator up in Montreal. And we love working with our Canadian colleagues. And after I showed this initial data a few years ago, I had Dr. Arnaud, who's this amazing breast surgeon or she was in Ontario, now she's in Vancouver. She reached out to me and I sent her my protocol and she copied and pasted it and swapped out lung for breast because she's a breast surgeon. And she did this trial very quickly where she gave patients immunotherapy with or without a dose of dupilumab while they were waiting for the operating room, because one of the issues in Canada is there's a little bit of a wait. Here, they only really waited about 2 weeks, so it wasn't that long of a wait. But she ran this up in Ontario. They actually just sent us all the tissue from this. So we're learning from all of this. We do very small studies, like this is a study with just 20 patients, but when you do really in-depth science, you can learn a lot from 20 patients, much more from 20 patients than many companies, who run a 200-person trial will ever learn because they don't invest a lot in the science and really understanding how their drug works. They just want to know if it works, not why. So that's just a little taste of some of the immune therapy research we're doing. And there's many, like I said, the immune system is extremely complex and it's different from one patient to another. And so a lot of our work is really understanding the complexity of the differences between one patient and another so that we can eventually develop more personalized approaches to immunotherapy. Mary Benjamin, question.
So if immunotherapy, according to my understanding, is a good thing because it would strengthen and train the immune system to respond better than before in patients with cancer, the insurance actually the insurance covers it, you know. So then why doctors refuse to prescribe it in early stages, for example?
Well, so it has to be approved for each stage. So it can be approved for stage 4 cancer, but it might not be approved for stage 1 or 2 or 3 cancer. And that's because the reason we need it to be approved in that setting is you have to know that it'll work in that setting. Because stage 1 cancer and stage 4 cancer are in many ways apples and oranges, and things that work for advanced cancer might not work earlier on or vice versa. So we always need clinical trials to prove that it works. And then once clinical trials prove it and the government approves it, then the insurance basically has to pay for it. But all of these drugs, these immune therapies that I'm describing, these are IV medicines given every 3 weeks. They cost anywhere from $200,000 to $1 million a year to administer. And so it's one reason why they're very stringent, the FDA and insurance companies, about who we give it to and who we don't. And if we don't have good evidence that it works in a certain patient population, they usually will reject it, which is understandable. And we never also, it's not just about money, it's also these medicines are not without side effects. And so we don't want to give somebody, we're always weighing risks and benefits. So we don't want to give somebody an immune therapy and have them risk all these side effects if they really aren't going to have any benefit. So a lot of the times patients will come in and say, well, why don't we just try it? Why don't we just try it? But when you weigh the risks and benefits, oftentimes it's not a good thing to try it because you're just possibly giving them lots of side effects with maybe a 1% chance of, benefit. All right. So how do clinical trials work? So there's a very long road from when we are in petri dishes in the laboratory and we're studying cells under the microscope to eventually testing them in mice. So we sometimes will do studies. I don't do this because I'm too much of an animal sucker, but we need to study these sorts of medicines in mice with tumors in order to know what we should actually put into humans. And so this oftentimes happens in the lab where we'll give mice a lung tumor and see if our new medicine gets rid of it. We oftentimes will study toxicity in monkeys. We don't give them tumors, but we'll give them a medicine and just make sure that it's not causing the immune system to attack the heart or the lungs, because obviously monkeys are much closer to us than mice. And then eventually we do clinical trials in human beings. And there's a bunch of steps. I would say, there's phase 0 all the way to phase 4 trials. We actually start with what we call preclinical studies. So this is before we get into the clinic. These are all the studies that are done on the tissue that we bring back to the lab from the clinic. And then also using a variety of models, whether it be in petri dishes or in mice or in monkeys. And we usually will get as much data as possible from that. And that really allows us, if we have a really promising drug, it allows us to, figure out exactly how often we should give it, most likely, and, gives us a general idea of what dose we should be giving. Sometimes they have something called phase 0 studies, and these are usually studies with very few patients, less than 10, 15 patients. And usually what they do is they take a brand new drug and they'll test very, very, very small doses in humans just to make sure they're safe. And these are in healthy volunteers. This isn't something that really ever happens in oncology. Usually we go straight into patients who have cancer because there's such a need. Also, it's very ethically questionable of giving healthy people, potentially toxic stuff. These studies in healthy volunteers typically only happen in Australia and New Zealand and England. For whatever reason, they have very lenient laws, I guess, and allow patients to sign, or healthy people to sign up to get these sorts of toxic drugs. There are then phase 1 studies. So this is really my expertise, is phase 1 and 2. And each phase asks a question. So you'll see in red is the question. So phase 1 is asking the question, is it safe? And so that's really the only main question that we're asking. We always want to see, does it work, and what are, the side effects and all those sorts of things. Well, I guess side effects is part of, is it safe? But what we do is we will do trials, and this typically happens at maybe 3 to 5 different clinical sites. So we might have a phase 1 trial that's open here at Mount Sinai, at Harvard, in Paris, somewhere in China. And between those sites, we'll put patients on, and we put, anywhere from 10 to 40 patients on most of the time for a phase 1. Usually in a phase 1 trial, it's what we call a dose escalation. So you start at a very low dose and you slowly work your way up. You'll treat 3 patients typically at a very low dose, and then you wait for a month or two. And then if everything appears safe, you go up to the next higher dose and you just slowly work your way up. And this is the reason why in my phase 1 program, we typically have about 3 dozen clinical trials open at any time. But if you come and see me today, I might not have any, studies available today. I might have one in 2 weeks all of a sudden become available, because a lot of the studies are doing this dose escalation where these 2-month pauses. And so this is another reason why when I talk to patients, we always want to meet patients ahead of time before they even need a trial, because we want to get to know them, make sure we have all their information, so that if and when they need a trial, hopefully we can immediately jump on it and offer them something. It's another reason why we always encourage patients to get second, third, fourth opinions. In New York City, we're blessed to have, 6, world-class cancer institutes. And so each of those institutes has different clinical trials. So I always have very different trials from Columbia and NYU and Sloan Kettering. So oftentimes it's good to see doctors at multiple places so that you have more options, if and when you need a clinical trial. These clinical trials, these phase 1 trials, they're really, the goal is to assess safety. They also assess what we call pharmacokinetics and pharmacodynamics, which is how quickly does the drug get into the blood and how quickly does it leave the body? How does it work? And the goal here is to say, should we be giving patients, let's say, a drug every day, or do we only have to give it every month? And that really, informs the next development stage of the drug. And we identify a bunch of these things like dose limiting toxicities, maximum tolerated dose, recommended phase 2 dose. These are all just abbreviations for things that we use, sort of dosing and recommended frequency of dosing that we use for the next stage. So this is just a schematic example. This is one of the trials I ran a few years ago. And here it's a dose escalation. So we started at 1 milligram of drug for every kilogram a patient is. So this is what we call weight-based dosing. Most chemotherapy is based on your weight, because you don't want to give a 100-pound person the same amount of drug as you give a 400-pound person, because the 400-pound person needs more. And what happens is you give it to 3 patients. If they do well, then you go up to the next dose, which is 3 milligrams. If they do well, you go up to 6 milligrams. And oftentimes what happens is then we'll also look at combinations where we might add drug X, this new drug, to drug Y, which might be immunotherapy or might be chemotherapy. And once again, you have to sort of do this escalation, because you always want to not give patients too much drug. We always are weighing risks and benefits. And then there's, like I said, pharmacokinetics and dynamics. This is just one example. Here they're looking at the amount of immune activation here on the y-axis. And you can see here as you go from up in the dose, so the smallest dose is in red, the next dose is in green, the next dose is in black. You can see here about 24 hours after the dose, you see a maximum increase of immune activation that goes down by day 8. And then you get redosed on day 22 maybe. So that sort of tells us we want to know exactly how long it's in the body, so we know how often we should be giving it. Once we have information on the safety and we've answered the phase 1 question, is it safe? We move on to a phase 2 question, which is it effective? So we're obviously in phase 1 hoping that we see it's effective, but that's not the main point of phase 1, is it's really to figure out exactly what the best dose would be. And then phase 2 is really where we say, how well does this work? And so oftentimes phase 2 trials might have 20 to 100 patients on them. They're treating most patients at recommended phase 2 dose. So at the dose that we think is potentially effective, but hopefully not too toxic. Sometimes the FDA now asks us to test 2 different dose levels just to see if we can get away giving a lower dose. So we sort of test a drug at the dose we think will be good, and then maybe half of the dose and see, maybe we can get away with less. Less is oftentimes more. And both phase 1 and phase 2 are what we call open label. This means that everyone knows exactly what they're getting. The patients know, the doctors know. There's no placebo, there's no secrets involved. There's typically no randomization where you put your name in a computer and it tells you, oh, you're getting this medicine versus this. But we do have that once it gets to phase 3. So if a drug does phase 2 and we say, oh, it is effective, we're seeing, 30%, 40%, 70% of patients have a response, we can then go on and do a phase 3 study. And phase 3, these are the studies that are needed typically in order to get a full FDA approval and allow us to be able to use these in standard practice from here to Indiana and everywhere else in between. So every step asks a question. So phase 2 said, is it effective? And phase 3 says, is it better than what we already have? And better can mean a few things. Better can mean more effective, so kills more cancer, lasts for longer, more cure. It can also, we always are wondering about toxicity. So sometimes we'll have a new drug that works just as well as far as controlling the cancer, but it's much less toxic than the alternative. So that's another way to say it's better. So better isn't always just, how long are patients living. Phase 3 trials oftentimes include hundreds, sometimes even thousands of patients in the breast cancer world. Very fortunately, most breast cancer patients do very well. And so, maybe 95% of people in certain situations of breast cancer are cured. And so to show an improvement from 95% to 97%, you need, 3,000 patients. And so much larger trials. When you look at pancreatic cancer, you only need a few hundred patients to see, if patients are benefiting, because unfortunately, those patients don't do as well as breast cancer patients. Typically, what happens with phase 3 studies is we say, here's a new drug, let's compare it to the old drug, what we call the gold standard. I say here, sometimes a straw horse is used, so maybe it's a gold standard, but a gold standard from 1999. But whenever we're designing one of these studies, you always have to meet with the FDA and make sure that the FDA agrees that you're comparing it to an appropriate comparator arm. Oftentimes, these trials will include placebos. Usually that's in the setting where, a patient might be getting what they would get normally, like chemotherapy, and then half of them get also they'll get immunotherapy and the other half get a placebo, and they won't know are they getting immunotherapy or the placebo, but everyone gets sort of the standard chemo. But obviously most people don't like placebos. I don't particularly like talking to patients about placebos. It's a necessary evil because it's the only way that we really know that drugs work. Because there's so many times when we've had the FDA approved drugs, and then subsequently when they do studies, where they include a placebo or the normal drug, they see, oh, it actually doesn't work. It just gives more side effects. So we have to do this sort of due diligence just to make sure we're giving patients good drugs that actually work. And an ideal design for a phase 3 trial is randomized, meaning patients are randomly assigned to one group or another. It's double blind, meaning I, as the doctor, don't know what you're getting. You, as the patient, don't know what you're getting. So we don't have our own biases, maybe influencing how we see things. And also that it's well stratified. And so stratification basically means, let's say in lung cancer study, you don't want everyone who's a smoker getting, one treatment and everyone who's not a smoker getting another treatment. Because then if you see a difference between the two treatments, is it related to the fact that they're smoking and had smoked in the past, or is it because the drug works better? So stratification means you want half of the smokers to be in this arm, half of the smokers to be in this arm, half of the non-smokers similarly to be in both arms. And a lot of the times we'll use a variety of stratification factors that we sort of plug into the computer. So the computer, when it's randomizing patients, makes sure that we'll have equal numbers of patients who are, smokers or non-smokers, and maybe in the case of ovarian cancer, equal number of women who are premenopausal and postmenopausal, because that can really affect the response to therapy and the biology. So I just told you about all the different phases. So this is old data from the FDA. I'd say the data is much worse at this point. But back in the day, we have all these drugs that are being developed in the laboratory that we call preclinical drugs. A very small percent of them, probably single digit, end up actually going into a phase 1 trial. From those patient trials or the drugs that go into a phase 1 trial, 70% of them can then go into a phase 2 trial. Of those phase 2 drugs, only about a third of them end up getting put into a phase 3 trial. And of all the drugs that go into a phase 3 trial, a quarter of them end up getting FDA approved. I think at this point, all of these numbers are much worse. So back in the day, it used to be for every 17 drugs that were tested in human beings, only one drug actually ended up getting FDA approved. Probably now it's closer to 30 to 40, which is a good thing and a bad thing. It's good because we have so many drugs that are being developed. It's amazing. But obviously, there's only so many patients that we can involve in clinical trials. And also, we don't want to be giving, drugs that are not going to be effective to patients. We want to increase the likelihood that the medicines that patients are getting in clinical trials are effective.